How often should I change baby's diaper? Changing your infant's diaper before each feeding will actually help wake them up so that they're ready to eat. So that's a good way to, get them awake and stimulating. In the first few weeks after I delivered, I would change my baby's diaper whenever switching from feeding on one side to the other, because often he would fall asleep nursing on one side. So to make sure that he got a full feeding, he would need a little help to wake up and eat from the other side. And then I could stretch him, those 3 hours to make sure his tummy was full. The first stool that we briefly talked about is called meconium, and it can be really sticky. So if you're having trouble getting it off, you can use a little bit of baby oil on a wipe, and your hospital actually should provide baby oil. And you'll notice that once your baby starts feeding well, their poop will actually transition to looking this greenish yellow and kind of seedy color. One thing they don't prepare you for is how much you will be talking about poop for the next 3 years or so, depending on when you potty train, but that is just a totally different discussion for a whole different day. And you can see on here that your nurses will be watching to make sure your baby has had at least one urine and one stool within the first 24 hours of life. And so usually you're given a paper to document that. They're going to want to know if you change a wet or poopy diaper. So just kind of keep that in mind. Got to make sure all those parts are working. All right, so this is a lot of info. So get ready and get your pen and paper ready. The transition period is a time where we watch baby super closely to make sure they're transitioning into life outside the womb well. This is usually considered from the time of delivery to 4 hours of life, so 4 hours of age. Every hospital will differ on how they view this period. Most of the time, you'll have a nurse that's designated to be in charge of all things that are related to your newborn. So typically, the protocol is to obtain the infant's vital signs every 30 minutes. Obviously, the time between each set can vary depending on what may be happening with your newborn. These vital signs can actually be obtained while baby is skin to skin, like we talked about, and like you see in the picture. However, your baby may be moved to a warmer so that the nurse can get a better look if need be. Again, this is one of those interruptions that might affect that golden hour of skin to skin, and I would request that your baby remain skin to skin unless necessary. However, try to remain flexible. Realize that your healthcare team is on your side. They want what's best for you and your baby. So if your baby needs to be moved, it's with you and your baby's best interest in mind. I put a star next to blood glucose because not every hospital checks the infant's blood sugar right away. Sometimes it's only checked if something else is abnormal. If you've been diagnosed with gestational diabetes, be prepared to have this monitored much more closely. That's something that you can talk to your OB about or your healthcare provider about. So as we look at each of these vital signs separately on the next few slides, I'm going to get into some normal variations that are really common. However, just try not to get overwhelmed. All of the potential problems that I'm going to cover still fall under the well baby category. So I'm not going to get into NICU stuff in this class, but we're just going to be talking about things that can happen that are pretty normal with a well baby. So let's look at each of these vital signs a little bit more in depth and separately. So let's start with infant heart rate. As you can see there, a normal infant's heart rate is 120 to 160 beats per minute. You're probably vaguely familiar with that number because at each of your appointments, usually the heart rate is monitored. But I just wanted to give you a comparison. A normal adult heart rate is 60 to 100 beats per minute. So babies' heartbeats flutter a lot faster than an adult. Okay, so your healthcare team will be sure to listen to your infant's heart really soon after birth. This is partly how we determine APGAR scoring, which you see at the bottom. APGAR is a quick assessment performed on the baby at 1 minute and 5 minutes after birth. The 1 minute score determines how well the infant tolerated the birthing process, and the 5 minute score tells us how well the baby is doing outside the womb, or in other words, are they transitioning well? Oftentimes, a heart murmur may be noticed when we are assessing your baby's heartbeat, and it's actually extremely common. It's not something to worry about right away, so if a murmur is mentioned, don't start WebMDing everything. Just wait to talk to your pediatrician and direct your questions to them. All right, infant respiratory rate. We have a lot to cover when it comes to respiratory rate. Like I said, I don't want to overwhelm you, so we're just going to try to cover the basics. And let's start with the normal rates. So as you can see, the infant respiratory rate is much higher than ours. Normal infant, 30 to 60 breaths per minute, and a normal adult is 15 to 20. One thing that is also very different about infant respirations is they aren't rhythmic, meaning they'll take breaths close together and then periodically stop breathing for up to 20 seconds. So this is actually called apnea. If that apnea lasts longer than 20 seconds, then something needs to be addressed, but it's totally normal for them to just and then they just hold their breath for 20 seconds and then they'll start breathing again. So when we're assessing proper respirations, we look in a few areas to make sure we don't see retractions or nasal flaring. Nasal flaring looks just like it sounds. The nostrils flare out when the infant takes a breath, and retractions can be a little harder to spot, but there are two places we look: suprasternally, which is just right below the neck, and subcostally, which is under the ribs. On the next slide, we're going to watch a video of what this looks like, so you guys can actually, put a picture to what I'm talking about. Okay, so as we keep going down that list here, tachypnea means your baby is breathing too fast. Likely, if your infant is showing any of these signs of respiratory distress, they'll also be grunting. A lot of families think that grunting is the baby's way of talking to them, but it actually means that the infant is experiencing some sort of respiratory distress and it needs to be addressed right away. And we actually will hear grunting on the next slide as well, so you can kind of have an idea of what that sounds like. It's important to note that if your infant shows any signs of respiratory distress after birth, you'll be asked to refrain from feeding them. Because of refraining from feeding them, a blood sugar will be tested to make sure your baby will be okay without eating until the respiratory symptoms are resolved. If the blood sugar is low, it's likely that your baby will need to go to the NICU to receive IV fluids so that we don't create a bigger problem. Okay, so before we watch this video, I just want to say I don't point out these possibilities to scare you. My point here is to educate you so that you can make an informed decision in the hospital. There are a couple things I want you to look for while we watch this video. Watch the infant's chest, and you'll notice him pulling in underneath the ribs with each breath. These are retractions. Listen closely for the sound the infant makes at the end of each breath. It may sound like normal infant cooing at first, but it's not. This is grunting. So we'll go ahead and play this video. Be stimulating the infant to cry. That's just normal. He's upset, but not grunting yet and crying. Your baby will be bulb suctioned at birth, and likely your nurse, so you can hear at the end of each breath that now he's grunting, like I said. So this causes the fluid and his ribs are pulling in. That's the retracting. Okay, so now on to the good news. There are quite a number of things that can be done by your healthcare team to resolve respiratory distress. The number one most non-invasive intervention would be stimulating the infant to cry. The way we do this is kind of by scratching their back or tickling their feet if they're having a hard time crying. Your baby will be bulb suctioned at birth, and likely your nurses will stimulate your infant to cry by rubbing their back, like I said. So this causes the fluid in the alveoli or the lungs to clear out. That's going to be our first, line of defense. If that doesn't help, the next most common intervention is Deli Section. This tube is inserted through the mouth and into the baby's stomach to help remove all that amniotic fluid that your baby was munching on in the womb. That's actually how they first start learning to eat. So with a vaginal delivery, most of this fluid is removed during that squeeze through the birth canal, but sometimes babies need a little extra help. And as you can imagine, with a cesarean section, they're going to have a lot more fluid because they don't get that squeeze through the birth canal. Amniotic fluid actually can't be digested. So the only way to get rid of it is for the baby to work it out through spitting it up or for us to suction it out. It seems really mean, but your baby will be so much happier without a tummy full of amniotic fluid, and they will likely breastfeed or take a bottle better. Okay, so here I just wanted to show a photo of the Deli Section actually being used if you look closely on there. So the tube is being inserted through the infant's mouth and into the stomach in this photo, and the fluid collects in the tube that you see near the infant's head. So we can also assess how much fluid is being suctioned out through that clear tube. We want, the fluid to be clear or yellow tinted is pretty normal. But if it has more of a brown tint, it means that the baby probably stooled while they were still in the womb, and so they've ingested that meconium, and we may need to assess a little bit further if that has happened. Okay, infant temperature. Thermoregulation is your body's ability to maintain a proper core temperature. Newborns aren't able to do that very well at all. They're kind of not so proficient in that area just yet. So this is why you should keep your newborn swaddled with 2 blankets and a hat, or skin to skin with blankets on top of you, especially while you're in the hospital, because the temperature of the rooms are usually cool. And this is especially important after the first bath. Most hospitals actually usually require your infant to be placed under a warmer for about 15 to 30 minutes after the bath to ensure their temperature comes back up, because we kind of freeze them out during the bath. A low temperature may indicate a low blood sugar, but not always. But if your infant's temperature is low, expect to have their heel poked so that blood sugar can be assessed. I don't think we've talked about that yet. That to obtain a blood sugar, it's a blood draw. Just like an adult would prick their finger, we prick the baby's heel. Sometimes when the infant is trying to warm themselves back up, they end up using their energy stores. Another word for energy stores is blood sugar or blood glucose. So you see the connection there. In this case, we want the baby to get in a good feeding, either under the warmer with formula or skin to skin with mom if you're breastfeeding, and with some warm blankets. So the hospital actually should come equipped with a blanket warmer if that's where you deliver, is a hospital. I am a total heat person, so when I was in the hospital after delivering my baby, I was always requesting a warmed blanket. They're just super relaxing and they feel good. A high temperature might indicate infection. So if your infant's temperature is high and they also have other signs of infection, or there were risks of infection at delivery, for instance, maybe the mother was GBS positive or spiked a fever, then the pediatrician might ask to get lab work done to rule out infection in your newborn. This often involves a heel prick and also a central stick, meaning an IV needs to be placed so blood can be drawn directly from the vein. In this instance, if an IV does need to be placed to get that central stick, if they get a good IV, they usually just leave it until we get blood results back so that we don't have to poke baby again in the case that, we're going to be delivering antibiotics to treat an infection. That can sometimes be hard on parents, but it's something that is for the benefit of the baby. Okay, infant blood glucose. We've kind of talked about this a little bit. So we're just going to try to stick to the basics with infant blood glucose here. Especially because every hospital or birthing center has a different protocol on if this is even checked. If the mother has gestational diabetes, then it will definitely be monitored. If the blood sugar is low, it is recommended that the infant either be put to the breast for a feeding or given a bottle of formula. The blood sugar will be rechecked 30 minutes after a successful feeding. If the infant's blood sugar is still low, they may give this course of action another chance, so feed the baby, check in 30 minutes, so they can allow the infant to eat again, or the infant might be given an IV of dextrose or sugar. That's what dextrose is in the NICU. Every pediatrician deals with blood sugar issues a little differently. A low blood sugar can cause potential brain damage, so it's important to fix this problem efficiently and effectively.